And then Brian, I'll go ahead and give you control. There we go. And you should have a little pop-up.
Very fine. Can you guys hear me okay?
Yep, and I can see your screen. Perfect.
Excellent. So this is a case that came in last week or so. Guy had been having a few months of respiratory issues and kind of an interesting radiograph, which unfortunately I did not find a way to port over. But we can see here he's got these arterially enhancing foci surrounding the trachea and right mainstem bronchus. They did a non-con, so you can see that although there is a little asymmetric right-sided mainstem bronchus airway calcifications, most of this is non-calcified. And he has a unilateral right pulmonary arterial atresia. And the other thing that's interesting here, so his pulmonary veins look pretty atretic. So he went on, his hemoptysis got worse. And you can see what's either hemorrhage or infection in the right lower lobe. And he went on to get a bronchial artery embolization, which was a very long and tortuous procedure. It took them about 7 hours, and they found hypertrophied feeding vessels coming off of multiple different vascular supplies, including, I think, the subclavian and axillary arteries. And he also had this study, this VQ scan, which shows kind of the limit of this study. It's probably that 2% is probably artifactual, but 100% of the flow was probably of the blood flow was going to the left lung. And he also has an echo showing signs of pulmonary hypertension. So now the question is what exactly to do with him, and I think everyone's leaning towards right pneumonectomy. And one thing I thought that was interesting about this was his pulmonary veins, how kind of atretic they look, and then B, just trying to think about this was the first time I ever really thought about what the what the drainage, the venous drainage of the bronchi would be, to the best of what we could find, it seems like most of it's traditionally through the pulmonary veins.
Part of it, yeah.
So, Brian, I showed a case of this last week. I can't remember if you were on or not.
I was not. No, I'm sorry.
No, it's great. It's a good discussion because my case was instantly detected. And this patient had abnormal radiographs going back 10 years or so, and it was called on the outside unilateral ILD for years. No one ever made the connection. But we picked up on the radiograph and had a CT, and for a different reason, but interesting, but I think I did mention because of the systemic arterial supply, they can get hemoptysis, but this is the first case I've seen of it. And the veins are usually very small. They form normally, though, but there's also a lot of bronchial venous drainage as well. But you can see that there's transpleural collaterals, and additionally to the hypertrophy bronchial arteries, you'll see what look like little nodules along the fissures and the costal pleura.
Yeah.
Right. Yeah, it's hard to know what to make of the veins other than they are not opacified. Are they patent? Are they very small? Because little blood flow is going to them. Oh, very interesting.
So, Jeff, on the case that you had, was the side that was called unilateral ILD, was that the normal side?
No, that was the abnormal side. Yeah, actually, show us the lung parenchyma, because the case I showed last week had peripheral cystic stuff.
Nothing really doing here. And interestingly,
no. Go down to the bottom. If you go slowly, at the very bottom, there was some peripheral black hole.
So this progressed over the last month or so.
No, keep going. Keep going. Right at the very bottom. Right out in the periphery, right there. See those?
Oh, yeah. Oh, interesting.
You had bigger cysts than this.
Yeah, mine looked more like bronchopulmonary dysplasia.
Oh, wow.
But I've seen everything from normal, just small lung, to very disorganized looking lung tissue.
Yeah, on the radiograph, the right side had looked small and hyperlucent relative to the left. So
Well, guys, we had a case about 30 years ago that was called sarcoidosis because there was an enlarged left hilum that was thought to be lymphadenopathy. And then in the right base, there was all of this reticulation in the base. And on CT, the reticulation was septal lines, probably from perfusion from the chest wall. And the left hilar lymphadenopathy was a large left pulmonary artery because the right pulmonary artery was not present. So that was another case of interstitial lung disease on one side related to this same condition.
Great. Well, thanks for letting me share, guys.
Yeah, thank you.
Yeah.
All righty. Travis says he had some audio issues too. So let's see. Howard or David, do you have cases this week?
I do.
All right. There we go.
The inadvertent disclosure of names in that.
Yep,
Okay.
it's fine now.
Okay. This person has a low-grade abnormality of the lungs here, perhaps a little bit of a ground glass abnormality in upper lungs. He's a fairly young man. And he had a radiograph now about a year later that looks like this, with really advanced lung fibrosis here. It seems to be concentrated in a mid-lung distribution here. The diaphragm has come up on both sides. The carina is probably being splayed a little bit, so we have this dense perihilar scarring process here. And then this is what CT looks like around this time. It seems to be made up of small nodules and then a peribronchovascular distribution of denser stuff here around the hyla. You can see probably some splaying of the carina here. Let's see what corona looks like. Corona helps bring this out. And you can see that this stuff is particularly dense along the posterior aspects of the upper lobe along the fissures, but it seems to be a fine nodular process out here. So it turns out that this is accelerated silicosis in the setting of, and here's the biopsy site over here, in the setting of a man whose job was cutting countertop materials, including a lot of synthetic materials that are made of rock dusts that are impregnated, that are bound together in resins. So there's both a chemical exposure in this kind of work, and then there's the rock dust exposure. And his job was cutting these countertops and cutting the holes for the sink and things like that, cutting the slabs of this material. He worked with a variety of synthetics, all of which, though, are composed of rock dust embedded in different kinds of resin. So I've got a list of the names of the products that he was involved with. So over the space of a little more than a year, I think, between the two radiographs, you can see he went from maybe some ground glass abnormality on the plain radiograph to this dense scarring here and accelerated silicosis here with approaching PMF status here. So these dust exposures in the modern workplace have not gone away, and a lot of people in these industries are really not that aware of the risks that they have in working on this material without proper respiratory protection. So accelerated silicosis.
So that was a year?
Wow.
I think that the distance between the radiographs was about a year. I think it was 2017 and 2018 that I showed you.
So it's like accelerated silicosis. Silicosis squared.
Yeah, accelerando here.
That's crazy. Can you show his lymph nodes? I'm curious if they're dense. Mildly. Yeah, they're a little denser than normal.
So a little
That's
bit.
something Chris and I've talked about. We've seen because you're accumulating the silica particles in the lymph nodes,
Right.
and they're radiodense, but that does not constitute silicosis. But then you start overwhelming the lymphatics and you get buildup. Brian just said there was a just something on ABC News about this from Australia, where they've also had an uptick in coal workers' pneumoconiosis as well.
Right. So the other place where you can see the lymph nodes from silicosis, and they may be calcified, is around the stomach, because people swallow this dust too. And so some of it gets into the GI tract and then is mobilized and carried in lymphatics. And so I've seen a couple of cases. This case I don't think qualifies, that had calcifications in lymph nodes that in the upper abdomen draining the stomach.
That is an impressive case. I don't think I've ever seen something move that quickly.
Yeah.
Because he must be doing this all day long, every day in very enclosed spaces to get that much dust. Because even sandblasters, we often see take a decade or so. I guess they're probably wearing protective equipment to some extent.
Well, one of the cases I like to show, and I can mobilize it for next time, was accelerated silicosis in a sandblaster, and the fellow was during 6 years before he had advanced silicosis, worked for a summer as a sandblaster during his college years. So he had a great summer job, paid a lot of money, and he was a sandblaster for just those 3 months. And then 6 years later, he has advanced silicosis. So in 6 years, and he was 32 years old at the time that we saw him with advanced silicosis. So, I think the particle size related to sandblasting and to sawing and stuff like that, you probably mobilize very fine particles that you can inhale deeply into your lung, and it's very potent. There was a story. The NPR has done a lot on this silicosis aspect of the modern coal workers' pneumoconiosis. NPR and then Frontline picked it up with a half-hour program in February on this black lung roaring back. And
that was an excellent story.
It was really excellent reporting. But around the same time on a Sunday, they had a story about people who were hired to build a tunnel in Georgia. They tunneled through some Appalachian mountain, and these guys worked on this, and I think it only took a few months to tunnel through this thing. But these people had accelerated silicosis. They were getting sick and dying within a year or two of this massive exposure. So here they were blasting rock and cutting rock and stuff like that, jackhammers and things like that, and just had very large exposures in a very short period of time, and then advanced silicosis within months and years. So you can really accelerate. I think it's all a question of concentration and particle size.
Yeah, and you wonder if the resin that hold these countertops together maybe make the quote stickier, so the mucociliary elevator can't clear it as well.
Maybe. Okay, those are my two.
Thank you, David. All right, Howard, Travis, I think you had audio temporarily. Or Howard, do you want to go?
Okay. This one we've all seen before, but it's such a nice example, an acute case. I'll just show it to you. So this is, at this point in time, just an observation only. And just to facilitate the observation, let me zoom in as well as move to the area that's interesting. See if you see anything. So that's part A of the question. Do you see anything? And number two, if you see anything, what non-imaging diagnostic device could one potentially employ to confirm your impression of what might be present here? Now that's a bit obscure, but I think you might get that.
Bubble study? Is that what you're asking for?
Something much more straightforward than a bubble study, another instrument.
Physical examination and eyeballs.
You could do that.
Listen.
with a stethoscope.
You can auscultate. It looks like there's something tubular and elongated there.
Yep. So we're going to listen for a bruit, if you see that, for sure. Yep, just a nice example.
Look around the mouth too and things like that.
Yep. Yep, this patient does indeed have HHT. And I can see this one rather nicely on the radiograph. This one, not so much, not really, but just a really nice example of 2 AVMs. And you can see the tubular nature of the opacities on the radiograph when you, particularly if you know that you've got the CT alongside it. So just a really nice example of 2 AVMs, quite large, right there. I would like to think that they would get something, a flow-related bruit, if you put a stethoscope there, I would think.
They can have cyanosis. Do they get clubbing too? I don't remember whether clubbing is part of it.
I think they can, but I don't think it's very common.
But their nail beds may be cyanotic.
Mm-hmm.
Here's also a really nice case. So the pathology here is actually right at the bottom, indeed in the abdomen, and really need just an image like that to suggest the diagnosis. There's no lung pathology, but this is the finding. And I think it might be the brightest one that I've seen, the brightest liver I've seen.
It's pretty dense.
Isn't that pretty bright?
Yeah.
Yeah.
So you're
That's
going to ask
pretty
us what
bright.
drug the patient's on, right?
Yeah.
Is there a spleen, Howard? I didn't see it. Didn't check for spleen.
Let's have a look. She is on amiodarone. Yep. Spleen looks all right. Lungs look okay. Yeah, one wonders if there's a little
Yeah,
abnormality
something
down
down
in the
there.
lung, but not terribly bad.
How about the thyroid? Usually it's pretty bright too.
Ah,
Yeah, it's pretty bright.
yeah, not so much compared to that. Yep, she's been on amiodarone for quite some time. So that's a acute case of that. Okay, I'm going to show you 2 cases of mobile aortic thrombus. You know, when we see that, we do teach that it's a potential source of embolism, and in these patients, you'll see that we do have that. So let's go to, I'll show you the abdomen in a second. Let's see here. So here, if you look at the aorta, interestingly, right off the bat, not only does this patient have the aortic thrombus, but also has pulmonary emboli. And I don't know if this patient and the consequences of that in the lung, whether the patient has a coagulopathy or not, that predisposes to both DVT and the formation of mobile aortic thrombi. But she definitely has it, interestingly. And let me show you the abdomen. So let me see, this is the lady, yep, where there's a ischemic bowel. You can see the enhancement of the wall. It's a little bit thick. And she has emboli to the bowel. I don't know for sure whether I saw, certainly not big emboli, but I do wonder about small embolus in a branch of, maybe there, of SMA. But definitely had clinical findings of bowel ischemia as a consequence of that. So that's case number 1. Case number 2.
So Howard, was there a PFO or anything?
Oh, let's have a look. I don't think so.
Or I don't know if they did an echo or something.
Oh yeah, with the emboli.
Yeah.
Emboli.
Yeah, that's a good question because it could be a hypercoagulable state, but I think I remember at least one case of paradoxical embolus that became adherent to the aorta.
Yeah. Seth showed us a case a
Didn't
couple
look
weeks
like it
ago.
from
Large
went through.
emboli, paradoxical embolism into the aorta. Here is the second patient as well. I'll show you this one. Here are the thrombi in distal aortic arch, descending aorta. That one's fairly sizable. Let's see if there are any more in the aorta at this time. Also had abdominal symptoms, and I'll show you really nice angio images of emboli in relation to SMA. So we have emboli in there. So mobile aortic thrombi with embolism to mesenteric arteries. It's interesting, we saw 2 cases like this in a fairly short period of time last year in close proximity to each other.
So how are those being managed at your institution? Because I know it's still a source of controversy and uncertainty.
As far as I know, well, both those patients had to be managed, both maybe surgically because of the bowel, but I think otherwise just anticoagulation, as far as I know. Here's a patient, just a reminder that everything that looks like a pretty typical thymoma, what ought to be a thymoma, in a small percentage of cases will not histologically or pathologically be a thymoma. I certainly don't know how to distinguish between a thymoma and what this is, which is a thymic carcinoma. So the histology that was taken out is that of a thymic squamous cell carcinoma. And they can both evaluate that under the microscope in the usual way, but they can also do immunohistochemistry if necessary to try and differentiate between thymoma and thymic carcinoma. And for example, this one is a P40 positive and the CD5 positive, supportive of that. And let's see if I have, this is just a basic summary of the kind of histology you can get with thymic carcinoma, so the whole spectrum of things, including squamous cell carcinoma. What this one doesn't have is the neuroendocrine tumors that you can have there as well. And there are other ones that are even rarer. But this one turns out to be that. Let me show you, and you guys do more MRI than I do. I do very little. So let me just show you, say, a vibe pre and a vibe at 3 minutes. So here we have, I wasn't that impressed by this. So this is pre, and that's vibe post. Is it enhancing a little bit, guys? A little bit?
A little bit.
Yeah.
Yeah.
A little bit?
Yep.
With the Gatto 3 minutes later.
Yeah. To your earlier point, Howard, I don't know what other people think, but I mean, unless there's metastatic disease, I agree. I don't find a good way to differentiate thymic carcinomas from just thymomas.
Yeah, I mean, there's really, I don't think, any good way, because it's hard enough just to tell different grades of thymoma. There was an abstract presented today that looked at diffusion weighted imaging and chemical shift and similar things. The diffusion weighted imaging can help, but it's really more to distinguish between a tumor and just hyperplasia and something like that. And it seems like the chemical shift is still the best for hyperplasia. But they're
Yeah.
surgical lesions, so it doesn't really matter up front.
Right.
Our goal is to look for metastases and clear, invasion that may make resectability an issue.
Yeah. Okay, let me show, I've shown them all, I think. Yep, those are my cases for this week. Jeff?
All right. Thank you. Travis, do you have a good enough connection to share cases?
Why don't you go ahead? I may show some later.
Okay. All righty.
Jeff, are you home now, or are you still at the meeting?
I'm at the conference. All right. So this is a 34-year-old male, and hopefully you should be able to see my screen. You guys see a CT okay?
Mhm.
Yep.
Okay, 34-year-old male who has a history of systemic lupus erythematosus. And I can't remember exactly. He presented with some sort of chest symptoms. I can't remember shortness of breath or chest pain. But this is a CT angio. And on a CT angio, you'll notice at the aortic valve, there's these funny filling defects on the valve plane and on the leaflets there. You can see that leaflets are open partially during systole here. And nothing else in the pulmonary vasculature. And he had an echocardiogram the day after. I'll put it in the cine mode, and you can see we're looking at the aortic valve here. Here's mitral valve, and this is the left, this is the outflow tract here, and you can see these thickened leaflets, and this is along the undersurface of the leaflets. So this is a case of Liebman-Sachs endocarditis, which is a non-infectious cardiac manifestation of lupus, where they get these vegetations on the leaflets. It's one of the more common cardiac manifestations of lupus. I haven't seen a case in forever, but it most commonly affects the mitral and aortic valves, and characteristically occurs on the undersurface. And the treatment is typically, suppression of the lupus flare as opposed to, any surgical intervention. I don't have any follow-up on the case, but it's just a really pretty example of Liebman-Sachs endocarditis.
Very nice.
All righty. While I'm sticking on valves, I'll show this case. This is something I did not know about. My colleague Chris Francois educated me on this entity. So this is a patient who has a repaired tetralogy of Fallot in her mid-40s and has a pulmonic valve prosthesis. You can see there on the axial images. And this thing is actually dehisced partially. let me put it in a different plane. It's a little easier to see. Actually, I should probably have just done, let me just change the window a little bit. There we go. So if we look at the valve, I can try to look at it probably best on she's also got a pulmonary arterial stent. But if we look at the valve, here we go on the coronal, we'll see that, get just far enough, there we go. So there's the valve, it's a bioprosthetic valve, that there's a dehiscence out laterally here on the left. And it turns out she's infected with Mycobacterium chimeriae, which I found an article on. I was not aware that this organism was associated with surgical repair of valves, but if you look for it, there's actually a whole bunch of papers on it. This was a nice review article recently. Mycobacterium chimeriae infections associated with heater-cooler units in cardiac surgery. So these are some of the cardiopulmonary bypass units. And the thought is it's actually contaminated at the main time of manufacturing. And there's a couple of epidemiologic studies on it, but it's pretty rare cause of lung disease. But cases, they usually don't see it as pulmonary, but they're seeing it in these medical devices, heater cooler units. They have a whole bunch of different brands, ECMO machines, various warmer blankets, a bunch of different, even water fountains. I don't know much about this organism, but it's one of these ones that has been associated with valves. It's pretty uncommon, but has been seen in patients undergoing cardiac surgery. So this presumably has led to the valvular dehiscence.
So you think it might be when the valve was actually being manufactured, or
the pump, the bypass pump?
So, okay, during the installation of the valve, not
and so that multiple patients at the same hospital can become infected with this. There's a couple they cite a bunch of case reports using DNA probes, and they found that they seem to be almost identical strains, and there was water samples at one, in the 11 patient strains. So there's this particular Levanova 3T heating cooling unit. So it's hard to know if it came from the factory or something like that. But they did actually interesting. They sampled the water pump where they produced these things and found the organism in the actual water system at the factory.
Really?
So yeah, I I never knew about this, or I hadn't heard of this particular organism before, but I did know the association with cardiac surgery. So if you do come across the organism, that's something you have to think about is, is a unit in your hospital contaminated? It sounds like it's not very common, but it has been pretty well described. There were several papers, there's case reports, there's a couple of epidemiologic studies, and this was a review article from, what was the date on this one? So it was first reported back in 2013. And this was reported in 2017, so it's a fairly recent review on this. And yeah, there was one of the bigger outbreaks was in Switzerland, and they have really good data. So this is where these authors are from. That's also a nice example of valve dehiscence. All right, and the last cardiac case, and I have one lung case. So this is a young person who had this chest radiograph for some non-related finding, and you see this sort of a funny contour at the aortopulmonary window. It's probably just thymus here. Typically, you'd think in a young person, but even for a young adult male, it looks a little bit full there. But it was thought to be thymic related. There's really nothing on the lateral view that suggests there's a big mass. That was done actually after the cross-sectional imaging, but just for the purposes of teaching. So he underwent a cardiac MRI for some unrelated reason, and what you'll see is there's this, I just have two sequences for this case, but there's this tongue of lung that has insinuated itself between the main pulmonary artery and the ascending aorta. And this is a pretty classic appearance of partial absence of the pericardium. And I couldn't find a great T1 sequence that would show the pericardium better. Here's a coronal as well, and this is just a cine loop, but it just shows you that the funny little orientation on the radiograph is probably related to that. You get that lung insinuating in there, and then there's probably a slight abnormal contour of the left atrial appendage in that area.
Yeah. And even the cardiac apex, the heart has a fairly distinctive shape on the frontal projection of the chest as well.
Because it's only a partial absence, right? You see a little bit down here.
If you go frontal, it's almost like the it's harder to describe than it is to recognize sometimes. I recognize that. I don't know, people have called it the falling heart, or it's something about it that's fairly distinctive pattern recognition wise.
But I think, Jeff, this is probably a complete absence of the left pericardium, which is the most common pattern.
Right, because of the early regression of the vein on that side.
Yeah.
Right.
Yeah. It's interesting. Often it falls back more posteriorly, the heart does.
Yeah, there must be
the
some
left
cardium down there. And you do see, I forgot to point out, he also has some leftward shift of the right heart border.
Mm-hmm. Yep. Yeah, it's a pretty nice example of that.
Yeah. Yeah, it's a really nice case. Nice. And with the radiograph, it's kind of fun. All right, and this is something we've talked about quite a bit on the webinar, but I saw a case, and this is another young patient, 44-year-old male, who has rapidly progressing lung disease. And I want to get these in the right order. So, so he presented short of breath at an outside facility and was noted to have this pattern of lung injury. So we see both peripheral and peribronchial, sort of a mix of consolidation in ground glass, opacity, and very distinct areas. Some of it's very perilobular, some of it's perivenous. So a good organizing pneumonia pattern. And so variety of diagnostic considerations, but in the setting of a connective tissue disease, which he ultimately is diagnosed with, the ones to think about early on are myositis. So that was at time point baseline. Here he is approximately, probably 3.5 months later. And you can see there's been progression of his lung disease. There's more of it. He's losing volume, and it's becoming sort of more confluent. So sort of not quite what we would call NSIP, but definitely a progression of his lung disease. And then here he is subsequently later than that, and you can see it's getting even worse.
Mm.
And so he does have the MDA5 autoantibody. So that's associated with the myositis dermatomyositis. So they don't often have the manifestations of myositis. You see, he doesn't really have any atrophy in his musculature, which you often see with myositis, but it's associated with really rapid progressive lung disease. And they also have many of them die from their pulmonary fibrosis because it's so progressive. Here's just a radiograph that happened midway along there, but it does show that sort of peribronchovascular basal peripheral predominance, and it's very small, these small lung volumes. It does have pleural effusion, which I think is unrelated, just very small, but this is an antibody confirmed. So amyopathic, that's what it is, amyopathic dermatomyositis and it stands for like melanoma differentiating antigen or something. I think, Travis, you've shown some cases of this, and maybe David and Paul.
Well, yeah, I think it was David and Sudhakar that had a few of them, and then I showed one recently that was more just fulminant respiratory failure over the course of days.
Yeah, this was over the course of about 3 months. So, but it tends to, I've seen, it seems to have an organizing pneumonia pattern early on that sort of looks like it's on its way to becoming an NSIP pattern. There's just so much collagen being laid down. So, all right. Well, those are my cases.
Okay, I'll try and show some here.
All right.
I used my phone for the audio. We'll see how my video feed is, though. Okay, you see a radiograph?
Yep.
Good.
So, as you can see, 38-year-old woman. It's a rather unfortunate case, but this was done. She experienced relatively rapid onset of respiratory failure. As you can see, she's intubated here. This is a few hours after the CT that I will show you. But she was transferred around midnight at this time to our institution from elsewhere. And the question, this was when I was on call, had to deal with her in the middle of the night, was the question, what is going on in her lungs? Meaning, should she be prone? Should they do aggressive measures, ECMO, etc.? So the interesting thing about this story is she'd had a history of cervical cancer 7 or 8 years ago. It had been locally recurrent in her pelvis, but no metastatic disease. And at the time, this was the only CT we had, and it had been read elsewhere as like probably a necrotizing pneumonia and septic emboli, but one of my on-call residents was astutely a little bit, less convinced that this was all infection. And I think some of it, you can see there are some nice little more discrete Cheerios. They have a little bit of more frosting around them, if you will, than we often see, but some of them are definitely look more like metastases than anything, or like adenocarcinoma than anything else. And we didn't have any prior imaging, but we did have a report from a CT from several years ago at the Outside Hospital where they described some bubbly lesion up here, in the right upper lobe, which had clearly increased in size, but I think it had been just kind of neglected for follow-up, and she hadn't had follow-up in several years. But thought maybe there was some acute pneumonia certainly going on here, but felt I was pretty certain at least a lot of this was going to be metastatic disease or, even primary lung adenocarcinoma, because we've seen that look similar to this. But we were able to afterwards get some more recent studies that showed, in fact, that she had progressive lung disease. But she actually passed away shortly after this, but the autopsy confirmed she did have a little bit of an acute pneumonia in the right middle lobe, but everything else was just widespread cervical adenocarcinoma that had metastasized.
So is it adenocarcinoma of the cervix?
Actually, I think so, David. I'll have to check and see. I'm pretty sure it was, though, not squamous. But it may have been like a uterine/cervical. I don't remember the exact, but it was. But yeah, it's not. My guess is we still don't have the old imaging, but my guess was she had metastatic disease early on that was not recognized. Kind of like the case of pancreatic cancer I showed a few months ago that had a solitary metastasis that looked like a primary adenocarcinoma that had been there for 4 or 5 years and finally blew up. So yeah, but I think like in these cases, when you look at the less affected areas and just some of these more discrete Cheerio-like lesions, that was more typical of cancer than of septic emboli. All right, so this is for David, since of course David emphasizes this point and has taught me to emphasize this point. This is a lady who, 21, was playing board games when she developed sudden onset of dyspnea. And you can see she went to urgent care, eventually ended up with a radiograph, and we can see a large pneumothorax. Now there is mediastinal rotation to the right, but I think that every time we see a big pneumothorax, we think tension. But I would argue in this case, David, that the mass effect on the diaphragm, maybe a little bit of inversion here, would favor more, would be the real finding that could suggest this patient had tension, rather than just mediastinal rotation from the loss of adhesion here. And also when she got, go ahead.
No, you go ahead, and then I will chime.
Okay.
Yeah.
She also has some, I think she has some pneumomediastinum here too, but the other thing was that on presentation, this is the other reason I showed her blood pressure was 55/40. So that was before they put a chest tube in. But yeah, go ahead.
The other clue that real is the spaces between the ribs. That's a big hemithorax.
Yeah. So yes, the space between the ribs is also expanded. The thing is that you can depress your diaphragm and you can spread your ribs like this anytime you get any pneumothorax. It's all just it's all a bunch of springs, and the ribs are being approximated and the diaphragm is being pulled up by the elastic recoil of the lungs. When you relax the elastic recoil by creating any pneumothorax, you'll start to spread your ribs immediately. You'll start to depress your diaphragm immediately. It doesn't require crossing a threshold called tension to cause those phenomena. So with any pneumothorax, you start to spread the ribs, you start to depress the diaphragm, and you start to shift the mediastinum. The mediastinum doesn't wait until you hit this magic threshold called tension and then say, okay, tension, yes, check.
Sure.
Time to shift, and it moves as a step function. It's continuous. So there are no radiographic findings that are specific for tension. And the strict
even the ribs?
Even the ribs. So the ribs are being approximated by the elastic recoil of the lungs. It's pulling everything inward, and it's pulling the diaphragm up, and it's pulling the ribs together. So it's pulling the mediastinum into position. So let's take the case of unilateral lung transplant. You can get a dramatic mediastinal shift in that situation, and you don't have a pneumothorax. You don't have tension. The pneumothorax is off to the side of lung fibrosis, and the side of the lung that was transplanted, which has normal elastic recoil, is stretchier than the stiff lung where there's fibrosis. And so the stiff lung has too much elastic recoil, and it pulls the mediastinum in its direction. That doesn't mean that there's tension on the right with that mediastinal shift. It's all just a question of relative strength of springs on both sides. And you've unbalanced the forces here.
Yeah.
So there are no radiographic findings that are specific for tension. And remember, the strict diagnosis of the strict definition of tension is that in the pleural space you exceed atmospheric pressure. And the reason that that's critical is because the patient will benefit if you make a hole in the chest if there is tension, because you'll let the pressure out. Okay, but the patient will not. That if you have a big pneumothorax and it's not tension, you make a hole, you're just going to potentially create more pneumothorax. So it's which direction the air is going to move that really determines the definition of tension. Air will come out of a pneumothorax if there's tension. The pneumothorax will just get worse. Air will be sucked in if it's not tension, and they can both be large like this. So there are no radiographic findings that tell you it's tension or not.
Yeah. Well, yeah, totally agree with the mediastinum. Yeah, I just thought that I know that clinically she had tension because her blood pressure was 55/40, indicating that she had impedance of venous return.
Good.
But yeah,
she's got a bad pneumothorax and it needs treatment. But
that's right.
The chest wall, just like the mediastinum, is just one of the things that's responding to the relative forces of all of these springs. And the spring is the elastic recoil of the lung.
And just to quickly show the nice example of re-expansion pulmonary edema too.
Mm.
Wow.
Yes.
So just a reminder that edema can cause consolidation, as we see here, kind of like in little lobular patterns and more dependent. So,
and it can affect the
well,
other
good.
side.
Yeah, because, what'd you say?
It can affect the other side. It can affect the contralateral lung, because there's a cytokine release that actually causes alveolar damage. The cytokine release in this abnormal lung here can affect, can cause consolidation to form on the other side where the cytokines hit normal lung.
And I think that was one of the cases I showed, like almost within the last year, of a patient that looked like they had contralateral effect from the cytokine release and ended up with respiratory failure from re-expansion edema. But this is just a nice example. But yeah, I mean, you're the only one that's taught me that, that the mediastinal rotation, is not a sign. I think it's still overemphasized that people think that that's tension. So, all right. Here's a quick one I'll show. This is one that, we've shown examples of this before. I think this is the best example I've seen. Actually, I'll show the old study first. So the key here, obviously, is there's a large renal cell carcinoma with invasion into the inferior vena cava, as you can see, and it's expanding inferior vena cava all the way up to the hepatic portion of the IVC. And at this point, there is, something that was, called as a PE, uncertain of whether it was going to be tumor embolus or whether it was just going to be bland pulmonary embolus. I think you can already say looks like there's little strands of enhancement there. But then I got to see this follow-up a couple months later, and you can see that not only is that finding still there, it has grown more centrally, and there are a couple of other findings as well. And we said, without a doubt, this was going to be tumor thrombus. The clinicians, just for completeness sake, a couple days later got a PET CT, and just to show you the correlate where there's no doubt. So this is, a macroscopic pulmonary embolism from macroscopic tumor embolism from renal cell carcinoma. And just a reminder, whenever you see filling defects, especially if they persist, then you have to think about tumor.
Travis, did you point out some lung vessels within the tumor embolism?
I think that it looked like on this one that there might have been, I don't even know if it was, this just looked a little heterogeneous here. Oops, get rid of that arrow, but right in there, it just looked like there was a little bit of vascularity to it, perhaps, right in here. It's just not, it doesn't look bland.
Is that the second?
And oftentimes we'll see, that's the initial study. Here's the second one.
Might have had some chunkier vessels actually feeding the tumor.
Yeah.
Are the bronchial arteries?
And it's right. And no surprise, the bronchioles have hypertrophied over time too. To supply, Yeah,
I think the presence of enhanced vessels is also another visual indication that you're dealing with tumor here and not thrombus. There are actually vessels feeding this highly vascular tumor.
Yeah. Now, of course, we would get bronchial artery enlargement in the setting of chronic thromboembolic disease, but that would be in the setting of a decreased caliber of an occluded vessel, not this increase.
Well,
but yeah, you're exactly right. Yeah.
It wouldn't be in the body of the tumor. It would be along the edges. You might see bronchial.
True.
This is actually in the tumor parenchyma.
Yeah. Yep.
Yeah. Looks like in the periphery.
All right. I'll show one more just because this is a kind of cute one that we had at the VA. So this is one where we definitely have pulmonary embolism here in the right lower lobe. But what's interesting about this, and the question was originally raised, was there pulmonary venous thrombus as well? And let me get the lower KV. This was a dual energy study. And I think that, when you see the PE there, and then we can explain the fact that this is just smoke in the pulmonary vein from slow flow in this same region, because there's upstream obstruction of the pulmonary artery in this case. And then there was an abdomen and pelvis study with a venous phase that clearly shows, from the same day, that there's nothing in that pulmonary vein there. So that was the slow flow. So there's unquestionably a PE, and then it's causing downstream smoke just from upstream of slow flow. So
Yeah, really nice demonstration of that.
yeah, we don't do a lot of perfusion imaging here, but there's definitely, no surprise, there's decreased perfusion to that area. So I just thought that was a nice one.
Yeah.
Very nice.
So, okay,
All right.
I will stop there.
Well, thanks, everybody. Glad we overcame our audio issues.
Jeff,
Yes.
was there any reaction to Varun's demo or whatever it was, his scientific or his educational exhibit on things that are not what you thought they were?
I'm at the other side of the world, so I don't know. That's in Hawaii.
What meeting are you at? I thought you were at Rankin Ray.
No, I'm in Paris at ST.
Okay, sorry. Okay.
Yeah, no, he did have it at our resident research day as a educational exhibit, and I did have several people comment on it to me that they liked it very much.
Okay, I hope we have success with that.
Well, one of my colleagues is in Hawaii. I'll text her later and see if she heard anything. But it looked really good, so he did a nice job on it.
Well,
Jeff, by the way, are you plugged in with a cable or with a Cat5 cable, or are you doing this all on Wi-Fi?
Who, me?
Yeah.
Yeah, I'm on Wi-Fi.
Wow.
Pretty good.
Okay.
Yeah.
Indulging some haute cuisine for us on our behalf.
Yes. All right. Au revoir. Bye.
All right.
Bye-bye. Take care.
See you next week.